So chronic pain is defined as pain that lasts more than 3 months. And that's the textbook answer of what chronic pain is. And the changeover from acute pain to chronic pain is that 3-month period. So in a nutshell, we're going to talk about understanding epidemiology and types of chronic pain, mechanism of action of chronic pain, and the points of where they change over from acute to chronic, and understand the treatment of chronic pain, including pharmacological and non-pharmacological options. So, definition of pain. This is from the textbook. An unpleasant sensory and emotional experience associated with actual or potential tissue damage. So there's a sensory and there's an emotional component together. I'll go into that in a little bit. And then the categories of pain. Well, acute pain is pain that occurs right now. And then chronic pain, again, this is something that goes beyond 3 months period. Acute pain, typically from disease, inflammation. The best example I can give you is someone hits you with a baseball bat. You get punched, gunshot wound. Those are types of acute pain. And then, or even just an ankle sprain. You twist your ankle. That's an acute pain, right? But then that should get better. But sometimes this doesn't get better in 3 months. That's when it becomes chronic. And that's when it becomes abnormal. You know, and the pain is your body's way of saying stop and listen to me. So when you sprain your ankle, that's good. And as you do the exercise and time goes on, the pain should lessen and you can put more weight on it. But if something is wrong with the signaling that goes back to the brain, it doesn't heal properly. So the pain never really subsides and it stays significant. Types of pain. In the setting where it's acute or chronic, we're gonna have doctors asking you to describe the pain. Sharp, shooting, electric, burning. Those are characteristics to give us an idea of, is it nociceptive, neuropathic, or mixed, or central pain. So nociceptive is something that occurs like from the baseball bat, and something traumatic. Neuropathic is something from the nerves, and like carpal tunnel, shingles, or diabetic nerve pain. And then mixed category is like migraine headaches, mixed neuropathic, nociceptive, cancer pain falls under there. And then central pain, well, that's everything that we experience has to be processed through the brain. And the central pain is sometimes someone has a stroke, and the part of the brain that processes pain is called the thalamus, and then you can get thalamic pain syndrome. So no medication can help that. So risk factors that can make pain chronic include, it's individualized, environmental factors, psychosocial, and pain inadequately treated acute pain. All these things lead to quality of life changes, including your mobility, your ability to sleep, appetite, mood, and your ability to function and work. Individual patient factors, that's a kind of given from person to person. Environmental influences. I think one of the things is like educational factors also is one of the things for risk in chronic pain. Being out of work for too long, it also promotes chronic pain. So that's why the 3-month marker shows, they've done a lot of studies to show that people that don't return to work within 3 months, chances are they're not going back to work. If we can get most people back to work within 3 months, then that plays into part of the psychosocial and environmental. So that way you help with their attitude and get them busy and moving. One of the biggest things for chronic pain is just keep moving. When you sit still, things start to hurt. This is the brain, and then acute pain. And you're going to see opioidergic. This is like OxyContin, Tylenol with codeine, Vicodin. That's why when you suddenly get hurt or you have surgery, they give you those pills because that's acute pain, the pain that lasts right away, and that should subside after the stimulus is removed. Chronic pain, so this is where it's associated with a neuropathic component, and it's not associated with the opioid system. This has a little bit of opioid system, but not so much, and you're going to see that we use different medications. Oops. We use different types of medication depending on the type of pain that you have. And going back to before, I asked like, describe the pain as burning or sharp, so it's nociceptive, neuropathic, or mixed. That kind of all plays into here, and it helps us decide what kind of medication to use at what part of the pathway for the pain. So you can see with the acute system, it's pretty straightforward, and it's very short. Trauma, and then sends a signal up to the brain. But when you have chronic pain, this signal, it gets sent up, and then it just stays here, and then comes back, and then goes back, and becomes aberrant. So it's not a very clear pathway. So what used to be a very simple pathway now it becomes complex because it doesn't know how to resolve the pain. So, pain transmission can be altered by mechanisms of peripheral and central sensitization. Function and structure, neurons and pathways involved in pain transmission are altered. This is basically just talking about how a signal from here goes to the brain and can be altered any way. That's really all this is saying. Chronic pain, so once you have the pain and it's there all the time, then it's a baseline pain with a period of inflammation or exacerbation. And those exacerbations can come from inflammation or neuropathic or mixed pictures. So that's why I have chronic pain modulation for inflammation. So let's just say you have back pain that's been long-standing. So you have back pain, but then you also you hurt yourself again on top of it. And that's inflammation on top of your chronic back pain. Peripheral sensitization. So, inflammatory compounds increase neuronal stimulation on the outside of the body, and then afferent C fibers contribute to local inflammation and releasing more of these inflammatory processes. And then, basically, peripheral sensitization means as there's more nerves being fired, it's getting more sensitive to the point where there's a stimulus that causes pain, and then it's not as effective for causing pain anymore. Let's see if I can explain that any better. Peripheral sensitization, transmission in afferent nociceptive neurons is increased. So because they're sending a lot of signals from whatever injury there is, now there is more nerves to pick up the signal. So that's what the sensitization is. So because you're always touching it, the body has to make more nerves for that touching. So that's what that stimulus is. So when pain becomes chronic, it shifts from noradrenergic and opioinergic pain. So norepinephrine, epinephrine, not really acting so much. And then opioid effect, not so much, because what is used for the acute setting now is becoming chronic because it's been long-standing. Talk to the patient, listen to the patient, and ask them how they're doing. I think a lot of people don't ask and listen. So that's the key thing here, asking and listening, and asking what the person's pain is, what brings it on, what makes it better, how did it come about, and how long has it been going on. There are different tools that we use. The number rating scale, the visual analog scale, the Wong-Baker with these silly faces. The number rating scale the number scale is really the best scale for the adults, from 0 to 10. Not so good for kids though. And then once there's a patient that we see with chronic pain and we feel that they may be good for pain medication, we do some tests to stratify them, like the opioid risk tool, the Dyer, another risk stratification to see if we should continue opioid medication These are just tools to determine. This is a very old picture from the World Health Organization, and it doesn't even, it says first step is non-opioids, aspirin, Tylenol. Second step, opioids with codeine. Third step, morphine, oxycodone. You don't see anything about non-pharmacologic here. Exercise, nothing. The World Health Organization, when they came out with this, they didn't even think about exercise. All they said was, here are some drugs for your pain. That's the problem with America. Really, the key things, non-pharmacologic intervention. Education is key. Physical therapy, exercise, movement, acupuncture, yoga, and just keep moving. And then, remember how I said there is a physical and then there's an emotional component? Well, this is the psychological and cognitive behavioral therapy. That's why there is an emotional component, and CBT is very important for chronic pain because there's a talking component that no one talks about. And then medical and technological interventions like a TENS unit or something like that, stimulation, and medicine for pain. But those are other interventions, and the first three are non-medical interventions. So I'm just going to go over the meds really quickly. Just opioid medication. Opioids, we have Vicodin, Percocet, OxyContin. Anticonvulsants like Lyrica and gabapentin. Antidepressants like duloxetine and Elavil, and Tylenol and NSAIDs. These are all, you see how there's seizure medicine, antidepressants, but those are for chronic pain. You don't see pain there, but they're used for pain because pain is multifactorial. It's not just like this. It's like this. It's in here. It's in here. It's in here. And in here. So that's why it has to be a lot of drugs, a couple of drugs, and exercise on top of it. Basically, opioids are the most #1 diverted pills from the hospital. And it's really what everyone is paying attention to right now. This is just a slide just basically saying codeine, fentanyl, morphine, oxycodone, methadone, Vicodin. These are the ones that are the hot buttons that people try to steal. 11% of Americans experience daily chronic pain in some form. Whether it's back, arm, shoulder. That's almost as much as diabetes. Opioids frequently prescribed for chronic pain because that's marketing from the Purdue, and it's easy for physicians to not talk to you and give you a prescription and get out of here. Verdad, right? Yeah. It's harder to talk to find out the real problem. Easy to give you a Band-Aid and get you to leave. Primary care providers commonly treat chronic pain and non-cancer pain. So they account for 50% of the pain medication. That's why there was a big information out like 2 years ago, because the primary care docs were pushing a lot of pills, more than specialists. And that's why there's this big problem now. So when you see the doctor and you say pain, we need to document, what kind of pain. Like I said, electrical, burning, nociceptive, neuropathic. What have you had for the pain? What have you done for the pain? What makes it better? What makes it worse? Do you have any other medical conditions? Do you have a history of substance abuse that can also affect the way that you need to use the medication? All these things we take into consideration in our documentation to support what you need to get better with your pain. Because looking at you, I basically ask, what is it that you want to do that you cannot do because of the pain, and how can we get over it? So we when looking at patients, we look at low and high risk patients. So low risk, someone not abusing medication, no history of substance abuse, and then we ask them to use only one pharmacy, one physician, and high risk patients, someone with a history of substance abuse, someone that loses their medications. All of these, regardless, should have pain agreements, and we do drug screening, and I ask them sometimes to bring their pills in for pill counts at the end of the visit. Tools, history and physical, documentation, and then in summary, chronic pain, it's multifactorial. Peripheral and central sensitization can make the pain worse, including inflammation as well. Nociceptive, neuropathic, and hypersensitivity, and it can be dysfunctional. meaning that it doesn't serve a purpose anymore. The original purpose of the pain was to tell your body to stop, but now it's dysfunctional, meaning that it doesn't serve a purpose. A multimodal approach, meaning multiple facets for the management and treatment of the disease, whether it's medication or non-medication. It's a little bit of both. Should be based on the underlying mechanism of the disease. So the treatment is geared towards, if you have arthritis, treat it towards arthritis. If you have a sprain, treat it towards a sprain. It's treated to what it is. And influencing factors, so basically look at genetics, other medications that may affect the medications that you may want to give someone. And then this is just saying a team approach is the way to go as far as working together and to try to treat someone's chronic pain and make it not so chronic.